So artifacts are non-pathologic field defects which may mimic glaucomatous field defects but are not due to any pathologic change or any pathology in the visual pathway, but they are due to performance errors or some difficulties during performing the test. Why it is important to identify the artifacts is that because these mimic glaucomatous field defects, they may be mistaken for actual glaucomatous defects, and they may also be wrongly taken when the patients have been monitoring, and then we assess progression in these patients. So identifying artifacts is very important. So artifacts, as I said, can be due to errors during the performance of the test. So we can divide these errors into these main topics. So there can be an error by the technician while performing the test. If there is a mistake or wrong data entry of the patient's data, improper correction of the refractive error or improper positioning of the patient, this can lead to some errors. There can be errors from the patient's side also, which can affect the reliability indices. Some of them are errors with the fixation losses, false positive and false negative errors. There can be, the patient has to understand how to perform the test. So it's a very important part of the examination that the perimetrist or the optometrist performing the perimetry has to explain the procedure to the patient well. So if the patient has not understood how to perform the test, there can be errors again. Some physical errors due to, or there can be some obstructions while performing these tests, and they can produce some physical errors. There can be some errors with the machine and sometimes errors with interpretation. So let us see all of them with few examples. So here is a perimetry which has been, there was an artifact because of the wrong date of entry of the date of birth. As you can see on your left side of the screen, this patient's age has been entered as 20 years, while actually he was a man of 74 years. So because his age was entered wrongly, the raw data, the actual threshold values were compared with a wrong age group, and hence there was a lot of defects seen on the mean deviation and few defects even on the pattern standard deviation. But when this was corrected and the right date of birth was entered, and when these threshold values were compared with the normative database, then we can see that the patient does not have many field defects. The field has improved a lot. Similarly, entering a wrong refraction can also cause some errors, can cause some artifacts. So this was a patient. On the left side, you can see the near correction has been given as 0. You can see the correction given on the field printout. Here you can see this. So because of this, there is a haziness, or the patient cannot be seeing the stimuli that are presented properly and will respond in a wrong way, and this will also affect the foveal threshold detection and can cause a generalized depression of the total deviation plot. So when his refractive correction was entered properly, he was a myope of 7 diopters. When this was entered properly, his near vision correction also gets corrected, and because of that he could identify the spots correctly, the stimuli that were presented correctly, and this has shown lot of correction in his visual field. Similarly, if the wrong eye is tested, for example, it is because of the placement of the patient's chin in the chin rest here, as you can see. If the patient is performing the right eye, the left, his chin has to be placed on the left side in this chin rest. So if that improper positioning is done by the optometrist, if it's by mistakenly done in a wrong way, a wrong eye can be tested and it can cause some artifacts. So incorrect fixation can happen when in the beginning of the test, as Dr. Ankur also explained, the central foveal threshold is first examined with the help of this central fixation target. The central diamond is used to do the first thing is to map the fovea with the help of these small diamonds. At these 4 diamonds are used to detect the fovea. When the foveal mapping is complete, the patient has to move his fixation to the central diamond, the bigger central diamond, and then the rest of the test is continued. But if the patient does not shift his fixation from these small diamonds to the central diamond, there is a incorrect fixation, and the fixation, the blind spot, everything will be shifted down because the patient will be seeing at a target which is 10 degrees below the fixation, and then there can be this kind of a downward shift of the blind spot. So when this was corrected, when the patient was explained to fix properly, this has improved the performance of the test, and the normal position of the blind spot is obtained on this right side of the printout. Again, fixation losses can happen. Fixation losses are in generally detected by presenting the stimuli in the area of the blind spot. So blind spot being perimetrically not responsive, if the patient responds to a stimulus presented within the blind spot area, that means the patient has moved the fixation. That's why the target was identified by the patient. So there are several catch trials during the entire test that is being performed, and this can be actually, this will affect the test performance of the test, and it's the duty of the perimetrist or the optometrist performing the test to monitor fixation. There are various ways to monitor fixation. One is by gaze tracking. As all of you know, there is a video monitor attached to the Humphreys perimeter where the optometrist can actually see how the patient is performing. Is he fixing properly or is he moving? And if there are a lot of movements, the patients have to be, the test can be stopped and the patient has to be explained again. So video monitoring during the test is one way of assessing the fixation losses, and also matching the lens center with the pupil center. So as you can see here, the green plus mark is the lens center. The lens is the lens which is placed in front of the patient's eye, the corrective lens, and the red cross is the center of the pupil. So as you can see in the first picture on the left, the two are not aligned properly. That means the patient is not fixing properly. So once the patient is explained, then so we should see that the two things coincide. And also sometimes if the patient has some macular problem, not able to understand and do the test properly, it is also possible to change the stimulus from size 3 to size 5. And also it's important to note the head position of the patient, because if the head is tilted, even then the patient will not be able to, because the stimuli will fall on the blind spot and that will increase the fixation losses. And this is the gaze track on the right side here, you can see. So this will be again also monitored during the test. And excessive movements of the eye, that means if the patient is not fixing and if constantly moving the eye, there will be deviation on the upper side of this graph, and those which appear on the lower side of the graph are because of a small deviation, or it can be because of a blink. So when the patient is again explained how to perform the test, how to fix properly, the test results do improve, as seen in the pictures in the center. So we have seen 2-3 examples where there are fixation losses, high fixation losses. So it can happen with a wrongly marked eye, and also with a wrong fixation with resulting downward displacement of the blind spot, and also because of the head tilt when again the stimuli fall on the blind spot area, and hence there are increased number of fixation losses. So when we see this kind of an increased fixation losses, we must think that one of these could be there, and the test has to be properly done again after explaining the thing to the patient. And because perimetry is a subjective test, the patients often find very difficult to perform the test in the first go. Patients do find difficulty in responding because the stimuli are very dim, and characteristically there can be defects in the mid periphery, or lot of, the field may look very bad if the patient is doing it for the first time. So it often takes sometimes 2 to 3 times of repetition of the test. And once the patient understands how to do the test, there is a definite, see here on the left side, there is a very, very abnormal field, but after explaining and after doing it repeatedly, the patient has now been able to perform the test well, and the field effect obtained on this side of the field is corresponding to the notch seen clinically. False positive responses. Sometimes patients are very anxious because it has been told to them that they have to fix properly, they have to respond only when the stimulus is seen. So they are very anxious to perform the test in a correct way. So they try to respond even when the stimulus is not presented. And sometimes a trigger happy patient also will respond. He just responds on his own even when the stimulus is not presented. So this will be recorded as a false positive response. So what happens here is usually the threshold values are of a very high value, because normal threshold values are between 30, 32. It should be usually a little equal to what is seen in the fovea, or even less than the foveal threshold. But in a false positive patient, where the patient is responding even with without the stimulus being shown, high threshold values are recorded as seen here, high values as high as even 40 or above 40. And this will result white scotoma seen in the gray field. There are a lot of fixation losses again because the patient responds even when the stimuli are shown in the blind spot area. There is a generalized increase in the hill of vision, and because of this, and when the pattern deviation plot is calculated, as was explained by Dr. Ankur, the 7th best point is taken and that is deducted from the total deviation plot. And because these patients have a very high threshold values which have been recorded in the raw data, they produce lot of defects in the pattern deviation plot as seen here. So the total deviation plot looks more or less better, but the pattern deviation plot shows lot of deviation than the total deviation plot. So, and the glaucoma hemifield test shows an abnormally high sensitivity. So excess high false positive. So all these signs indicate that the patient is having a very high false positive response. Again, patients have to be explained, the test can be paused, patients have to be explained again, and the test has to be done again, because this is a very important index, because here, because the patient is responding very much, there is a high possibility that glaucoma may be missed. So it's a very important index, and this has to be corrected by proper counseling of the patient. Similarly, false negative response is another artifact that happens, because if the patient is, normally what happens when the patient starts to perform a test, the patient understands and responds properly when the central points and the 4 cardinal points are being tested, and as the test progresses, the patient becomes inattentive and the peripheral points show lot of depression, and hence this will produce a clover leaf pattern, because central points are detected and the patient has been performing properly and the peripheral points show a lot of depression. This produces a clover leaf pattern, and false negative response here is very high and the test is flagged off with 2 cross marks. So this again has to be identified. This is an artifact, but this can also happen when the patient is having a very advanced field loss. Because of overlapping of the fields, the patients will not be able to perform the test well. There can be high positive, false negative responses. So in either case, so this can happen, as I said, because of an inattentive patient or because of fatigue, because initially patient is attentive and responds well, but as the test progresses, he becomes inattentive. So in this case, again, pause the test, explain to the patient again and repeat the test, and if required, we can change the stimulus from size 3 to size 5. And another type of artifact that can happen is because of some obstruction during the performance of the test. So for example, it can happen because of the thick rim of the lenses that have been used for performing the test. And if the lens which is placed in the holder is not placed correctly, if it's placed too much away from the patient, that will produce a edge artifact. It can produce a rim scotoma or a edge artifact. So here it is because sometimes it can happen even with a small pupil, because that produces peripheral constriction of the field of vision. And it can also be because of a prominent orbital margins or a prominent nasal bridge also. So I said small pupil size, average pupil size has to be 3 to 3.5 millimeters, and this should be kept constant in rest of the tests that have been performed as a part of regular examinations. So small pupils, constricted pupils, especially in senior elderly patients, we can slightly dilate the pupil and do the test. So as I just said, so one more artifact is because of the ptosis or blepharochelosis. Because of that, the upper points here will produce very dark defects, and they may mimic a superior arcuate scotoma, but it's because of the either ptosis or blepharochelosis. So a proper correcting tape can be used, and then when the test is repeated, the patients can perform well. Similarly, a tilted head position or a prominent nose can also produce edge scotomas in this way. So as was just said in the previous talk also, threshold values with values less than 1, less than 2, so they can happen because of some machine error, because the complete intensity of the light is not projected, probably because of a null-functioning bulb of the perimeter. So that has to be noted, and when that is the case, the test can be performed after correcting the machine problems. So there can also be some non-glaucomatous defects or non-glaucomatous fundus pathologies that can produce field defects similar to that of glaucoma. So here, because this patient was a high myope with large peripapillary atrophy, this was producing a very dense superior arcuate scotoma. So this was this could be mistaken for a glaucomatous field defect, but when we examine the fundus very carefully, this we can see a large disc with a myopic crescent. So this field effect was because of the myopic tilt and a large myopic disc, but not because of a glaucomatous rim loss. Similarly, myelinated fibers, optic disc drusen, these kind of optic disc pathologies can also result in an enlarged blind spot. So always this may not be due to glaucoma, and only when the fundus is carefully, so basically we need to correlate with the fundus image and fundus examination, and then only decide whether the defect is because of the glaucoma or due to some other pathology in the fundus. Similarly, this case, as you can see, there is a peripheral constriction of vision, and this could be because sometimes can be confused that because of a large advanced glaucomatous defect, but when the patient was seen completely, it was because of the retinitis pigmentosa producing this kind of a peripheral constriction of vision. And it can also be seen in some cases of primary optic atrophy, sometimes even with extensive panretinal photocoagulation. Similarly, this patient, as we can see, there is a superior arcuate scotoma with macular threat, but this was not due to directly because of glaucoma, but this patient on fundus examination was found to have an inferior branch retinal vein occlusion. Similarly, very pale discs because of some neurological cause can also produce advanced field defect, but that has to be again correlated clinically. Same thing here. So it's very important to identify the artifacts. That means they may appear, they will simulate the glaucomatous defects, but it's very easy to differentiate between the artifacts and the actual glaucomatous defects by proper correlation with the fundus picture. And it's very important to enter the patient data correctly, explain the patient how to do the test. If required, it has to be done again and again. The patient may need repeated instructions to do the test properly, and very important to monitor the performance of the test during the test, and we can change the test strategy so that the results improve. So clinical correlation is very important, and never interpret visual fields in isolation.
Okay.
Thank you.